Very good morning to all of you students. Today our topic of discussion is endocrine system, and I'll be dealing about thyroid, neoplastic and non-neoplastic disorders. I'm Dr. Bharathi, Assistant Professor, Department of Pathology. So the endocrine system is a highly integrated and a widely distributed group of organs that maintain a state of equilibrium among various tissues of the body, signaling by extracellular secreted molecules. So it can be as autocrine, paracrine, and endocrine. So endocrine signaling is mainly by the secreted molecules, which are called as hormones. So the endocrine system mainly comprises of pituitary, thyroid, parathyroid, endocrine pancreas, adrenal, and also we are going to deal about some of the MEN syndrome, multiple endocrine neoplasia syndrome. So let's have a brief discussion about the endocrine system before moving on to the thyroid gland proper. Hormones can be classified into several broad categories based on the nature of their receptors. Hormones that trigger biochemical signals upon interacting with the cell surfaces, and hormones that diffuse across the plasma membrane and interact with the intracellular receptors. So the endocrine diseases can be classified as diseases of underproduction or overproduction of hormones with associated biochemical and clinical consequences. Diseases associated with development of mass lesions, which may be non-functional or may be associated with overproduction or underproduction of hormones. Now moving on to the endocrine pathology of thyroid. As we all know, the thyroid gland consists of two bulky lobes, lateral lobes, which are connected by a relatively thin isthmus. This is located below and anterior to the larynx. It develops embryologically from an evagination of the developing pharyngeal epithelium. It descends from the foramen cecum at the base of the tongue to its normal position in the anterior neck. So this is the anatomy of the thyroid gland. You have both right lobe and left lobe, which is connected together by isthmus. This is the gross picture of the thyroid gland. The thyroid is divided into lobules. Each is composed of about 20 to 40 evenly distributed follicles. The follicles range from uniform to variable in size, and they are lined by a cuboidal to columnar epithelium, which is filled by thyroglobulin, the iodinated precursor protein of the active thyroid hormone. This is the histopathological picture of the thyroid, where you can see the follicles which are lined by low columnar to cuboidal epithelium, and which the follicles are filled by colloid. Now moving on to the disorders of thyroid. The disorders of thyroid can be because of excessive secretion of T3, T4, which causes hyperthyroidism, decreased secretion of T3 and T4, which causes hypothyroidism, inflammation of the thyroid gland causing thyroiditis, Graves' disease, which is yet another category. It causes hyperthyroidism. We are going to deal about Graves' disease in detail, goiter, and neoplasms of the thyroid. Coming to hyperthyroidism, coming to thyrotoxicosis. What is thyrotoxicosis? Thyrotoxicosis is a hypermetabolic state which is caused by elevated circulating levels of free T3 and T4. Increased hormone levels with hyperfunctioning of the thyroid gland. What are the causes of thyrotoxicosis? It may be because of diffuse hyperplasia, for example, Graves' disease in about 85% of the thyroid, 85% of the cases of hyperthyroidism are mainly because of Graves' disease, or it may be because of hyperfunctional multinodular goiter, or it may be because of an adenoma. Adenoma is just a benign nodule which secretes excessive T3 and T4. So what are the symptoms? What are the symptoms of hyperthyroidism? So the patient will have hair loss, there will be lid retraction, exophthalmos, lid lag, the patient will have goiter, and coming to the cardiovascular system, the patient will have tachycardia, palpitation, atrial fibrillation, weight loss, and the patient will have diarrhea. The patient will have warm, moist palms, tremor, oncholysis, acropathy, pretibial myxedema. The patient will have osteoporosis, menorrhagia, and weight loss. What is thyroid storm? Thyroid storm is used to designate the abrupt and severe onset of hyperthyroidism. This condition occurs most commonly in patients with Graves' disease, resulting from an acute elevation in catecholamine levels during stress, surgery, and trauma. So, the thyroid storm is a medical emergency. If it is untreated, patients die of cardiac arrhythmias. So the diagnosis is mainly with the help of T3 and T4. The T3 and T4 will be elevated in this condition and the TSH will be diminished. So the measurement of serum TSH is the most useful single screening test for hyperthyroidism. TSH levels are decreased even at the subclinical stages. Now moving on to the Graves' disease. In 1835, Robert Graves reported on his observations in the female that there are violent and long continued palpitations in him. This is mainly because of the enlarged, and they also had enlargement of the thyroid gland. So Graves' disease is the most common cause of endogenous hyperthyroidism. It is categorized by a triad of manifestations like thyrotoxicosis, infiltrative ophthalmopathy, and pretibial myxedema. Thyrotoxicosis is caused by a diffusely enlarged hyperfunctional thyroid. The peak incidence of Graves' disease is about 20 and for 20 to 40 years. Women are more commonly affected than men. That is, women are affected 7 times more commonly than men. So the genetic factor, the family members of affected patients are more commonly affected, and the concordance rate in monozygotic twins is found to be about 60%. Moving on to the pathogenesis of Graves' disease. Graves' disease is an autoimmune disorder. It is characterized by a breakdown in the cell's tolerance to thyroid autoantigens, of which the most important is the TSH receptor. So what are all the antibodies which are developed? Thyroid stimulating immunoglobulin, thyroid growth stimulating immunoglobulin, thyroid TSH binding inhibitor immunoglobulin. So these are all the antibodies which are developed against the antigens, self-antigens. So what is the morphology of the thyroid gland? The thyroid gland will be diffusely enlarged. There will be diffuse hypertrophy and hyperplasia of the thyroid follicular epithelial cells. The thyroid is smooth and soft with the capsule intact. The cut section of the thyroid is usually meaty and soft in appearance. Coming to the microscopy, the follicular epithelial cells are usually tall, columnar, and more crowded. Sometimes you can see small papillae containing colloid with scallop margins and lymphoid infiltrate with plasma cells. This is the histopathological picture of thyroid. Here you can see the follicles are lined by tall columnar epithelial cells which project into the lumens of the follicles. The cells actively resorb the colloid in the center of the follicles, so that's why they have a scalloped appearance. Can you see the scalloped appearance here? So they resorb the thyroid, the follicles resorb the thyroid from the center, they have a scalloped appearance, and you can see they are lined by tall columnar epithelial cells. Sometimes you can see tiny papillae which is seen projecting into the lumen of the follicle. So what are the changes in the extrathyroidal tissue? In lymph node, you can see generalized lymphoid hyperplasia. Coming to the heart, you can see hypertrophy with ischemic changes. And in the skin, you can see infiltrative dermopathy, which is characterized by thickening of the dermis. So why there is thickening? This is mainly because of deposition of glycosaminoglycans and lymphocyte infiltration. This is most commonly seen in the skin overlying the shins. There is scaly thickening and induration of skin. So it gives an appearance of an orange peel. It has a texture of an orange peel texture. Okay. So this is infiltrative dermopathy. Coming to infiltrative ophthalmopathy. This is mainly because of marked infiltration of retroorbital space by mononuclear T cells. There is inflammatory edema and swelling of the extraocular muscles. This is mainly because of accumulation of hydrophilic glycosaminoglycans and increased number of adipocytes. So this is a picture showing a patient with Graves' disease having infiltrative ophthalmopathy. The patient is having exophthalmos, lid lag, etc. What are the clinical features of Graves' disease? There is diffuse enlargement of the thyroid gland. There is sympathetic overactivity. There is wide staring gaze and lid lag. And there is exophthalmos. Exophthalmos means abnormal protrusion of eyeball. There is infiltrative dermopathy or pretibial myxedema, elevated free T4 and T3 levels, and depressed TSH levels. Moving on to hypothyroidism. Having seen about hyperthyroidism, now we are going to talk about hypothyroidism. Hypothyroidism mainly occurs, it is mainly a structural or functional derangement that interferes with the production of thyroid hormone. What are the causes of hypothyroidism? Any developmental defects, radiation injury to the thyroid which causes decreased secretion of T3 and T4, surgical ablations, and one of the most common cause of hypothyroidism in females is Hashimoto's thyroiditis, which we will be dealing in our subsequent slides. Okay, and interference with hormone synthesis, like it can be idiopathic or it can be heritable biosynthetic defects and iodine deficiency. So what are the symptoms of hypothyroidism? The patient will have low cerebration, that is the patient will be fatigued all the time. The patient will have dry hair, myxedemic face, which is a typical complexion of a patient with hypothyroidism. There will be changes in voice, and the patient will have psychosis, loss of outer third of eyebrows, deafness, and ischemic heart diseases like ECG changes, bradycardia, etc. And the patient will have diminished sweating, weight gain, menstrual irregularities. The patient will have constipation. The skin will be dry, cold, and it is prone to hypothermia. Patient will have cold intolerance, muscle weakness will be there. Now, the next new term, that is cretinism. What is cretinism? Impaired development of skeletal system and CNS. Cretinism usually occurs in children. Okay. So the patient will have mental retardation, short stature, coarse facial features, protrusion of tongue, and umbilical hernia. So as the mother is hypothyroid, the patient won't be getting enough T3, T4. If it is not treated, the patient will end up having, the baby will end up having cretinism. Okay. What is myxedema? Hypothyroidism developing in the older child or an adult is called as myxedema, whereas cretinism is hypothyroidism developing in a young children or in the fetus as the mother is hypothyroid is called as cretinism. Okay. Measurement of the serum TSH level is the most sensitive screening test for this disorder. Now, what is goiter? Goiter is nothing but just an enlargement of the thyroid gland. It can be diffuse or it can be multinodular goiter. It is mainly because of impaired synthesis of the thyroid hormone. It is caused by dietary iodine deficiency. So there is compensatory rise in the serum TSH level. There is hypertrophy and hyperplasia of the thyroid follicular cells. There is gross enlargement of the thyroid gland, and the patients mainly will be in the euthyroid state. What is endemic goiter? In geographic areas where the soil, water, and food supply contain low levels of iodine, this endemic goiter is most commonly seen in mountainous areas and Himalayas. It is present in more than 10% of the population. What is sporadic goiter? It occurs less commonly than endemic goiter. The condition is more common in females than in males, with a peak incidence in the puberty or young adulthood. When there is an increased physiological demand for T4 And this may also be due to ingestion of substances that interfere with thyroid hormone synthesis, such as excessive calcium and vegetables, which are belonging to Brassiaceae family, that is cruciferous family like cabbage, cauliflower, Brussels sprouts, turnips, etc. It can also be due to hereditary enzymatic defects. It is This hereditary enzymatic defects interfere with the thyroid hormone synthesis. This is transmitted as an autosomal recessive trait, and this condition is called as dyshormonogenetic goiter. Moving on to the diffuse non-toxic simple goiter. It is mainly because of the enlargement of the entire gland without nodularity. The follicles are enlarged and they are filled with colloid. There are two phases. One is hyperplastic phase and the other one is phase of colloid involution. In hyperplastic phase, the thyroid gland is diffusely and symmetrically enlarged. The follicles are lined by crowded columnar cells. They form projections. What is colloid goiter? The dietary iodine deficiency increases, and if the demand for thyroid hormone decreases, the follicular epithelium involutes to form enlarged colloid-rich gland. So grossly, you will see brown, glassy, translucent, colloid-filled areas in the thyroid. And histologically, the follicular epithelium is flattened and cuboidal and colloid is abundant inside it. The clinical course, simple goiters, clinically it is euthyroid. The mass effects from the enlarged thyroid gland. The patient may have dyspnea, dysphagia as the enlarged thyroid gland compresses on the trachea. The serum T3 and T4 levels are normal. Serum TSH levels usually are elevated or at the upper range of normal. What is multinodular goiter? Because of the recurrent episodes of hyperplasia and involution of the thyroid gland, there is irregular enlargement of the thyroid, which leads to multinodular goiter. All long-standing simple goiters convert into multinodular goiters. They are mistaken for neoplastic disease. Morphologically, the thyroid gland is multilobated and there will be asymmetrically enlarged thyroid glands. Pressure on midline structures, trachea and esophagus, which causes dyspnea and dysphagia. And sometimes the goiter is so large that it grows behind the sternum and clavicles, which causes intrathoracic plunging goiter. This is a morphological picture, that is gross picture of a multinodular goiter. On cut section, there are irregular nodules containing variable amounts of brown gelatinous colloid. Older lesions will have areas of hemorrhage, fibrosis, calcification, and cystic change. So this is the cut section. Here you can see so many colloid-filled nodules, areas of calcification, and areas of hemorrhage can be noted. Microscopically, there will be colloid-rich follicles which are lined by flattened inactive epithelium and areas of follicular hyperplasia. So this is a histological picture where you can see colloid-filled follicles which are lined by flattened cuboidal epithelium. The clinical course, the mass effects of the enlarged thyroid gland, obvious cosmetic effects, large neck mass, airway obstruction will be there, the patient will have dysphagia and compression of large vessels in the neck and upper thorax, which causes superior Vericava syndrome. Most patients are euthyroid. There is autonomous nodule. Sometimes there may be autonomous nodule which causes hyperthyroidism. That in that condition is called as toxic multinodular goiter, otherwise called as Plummer syndrome. The incidence of malignancy in long-standing multinodular goiters is low, which is less than 5%. There is sudden change in the size or the symptoms. That is, the patient can complain to you with hoarseness of voice, and fine-needle aspiration biopsy is useful in that condition. Moving on to the next condition, that is thyroiditis. Thyroiditis is nothing but inflammation of the thyroid gland. It can be acute, subacute, or chronic. Types of thyroiditis. In case of acute, that is of sudden onset with severe thyroid pain, it can be mainly because of any infections or granulomatous thyroiditis. If it is subacute lymphocytic thyroiditis. If it is chronic, it can be Hashimoto thyroiditis or chronic lymphocytic thyroiditis. This is how you classify thyroiditis depending upon the time of onset of the condition. Chronic lymphocytic thyroiditis, that is Hashimoto thyroiditis. This is a very important question. This is the most common cause of hypothyroidism. It is characterized by gradual thyroid failure. It is an autoimmune destruction of the thyroid gland. It is most commonly seen in the age group of 45 to 65 years of age, and it is more common in women. Pathogenesis, it is an autoimmune disease. There is progressive depletion of the thyroid epithelial cells, and there is mononuclear cell infiltration and fibrosis. So there are multiple immunologic mechanisms which causes Hashimoto thyroiditis. It is mainly because of autoreactive CD4 T helper cells to the thyroid antigen. And CD8 cytotoxic T cells act against antigens on the thyroid cells. And there is also antibody dependent cell mediated cytotoxicity. That is mainly because of NK cells. So there are three main immunologic mechanisms which causes hypothyroidism. So this is the thyroid epithelium, T cell sensitization to the thyroid antigen, helper T cells, CD4 T cells, which produces interferons, which activates macrophages and it destroys the thyrocyte. CD8 has cytotoxic, it is a cytotoxic T cell which causes T cell mediated cytotoxicity, and this is the plasma cell which produces antibodies, and the antibody destroys the thyroid cells. Coming to the genetics, there is increased frequency in first degree relatives, and unaffected family members might have circulating thyroid antibodies, and it is also associated with other autoimmune diseases. Morphologically, the thyroid is diffusely and symmetrically enlarged. The capsule is intact. The thyroid is well demarcated from the adjacent structures. On cut surface, the thyroid is pale, grey tan, firm, and friable. This is the gross picture of a thyroid, Hashimoto thyroiditis. Microscopically, there is mononuclear inflammatory infiltrate, small lymphocytes and plasma cells. There is well-developed germinal centers, and the thyroid follicles are atrophic, which is lined by epithelial cells with abundant eosinophilic granular cytoplasm. These cells are called as Hürthle cells or oxygen cells. Hürthle cells have abundant granular eosinophilic cytoplasm, which is mainly because of prominent mitochondria inside them, inside the cytoplasm, and the interstitial connective tissue is increased. So this is a patient where you can see so many Hürthle cells, and there is lymphoid follicles. See, here you can see atrophic thyroid follicles which are lined by Hürthle cells, and there is dense inflammatory infiltrate with germinal centers. These are the Hürthle cells, and this is the lymphoid follicle. Clinical feature, there is painless enlargement of the thyroid. The patient will have features of hypothyroidism. It is most commonly seen in middle-aged women. The thyroid is enlarged symmetrically and it is diffuse. There is T3 and T4 levels will be decreased, and there is compensatory rise in TSH levels. There is a chance of development of B-cell non-Hodgkin's lymphoma. Moving on to the next topic, that is subacute granulomatous thyroiditis. This is less common, and it is seen most commonly in the age group of 30 and 50. It is most commonly seen in women, and it is seen after post-viral infections. Morphologically, the gland is firm with an intact capsule. The gland is unilaterally or bilaterally enlarged. Histologically, there is disruption of the thyroid follicles. There is inflammatory infiltrate, which is mainly composed of lymphocytes, plasma cells, and macrophages. And there is extravasated colloid, granulomatous reactions, and giant cell reactions are always seen. And healing is by resolution of inflammation and fibrosis. Coming to the clinical features, there is acute pain in the neck. The patient complains of fever, malaise, and enlargement of the thyroid. There is a transient period of hyperthyroidism, which mainly occurs because of the disruption of the thyroid follicles, which secrete excessive thyroid hormone. The leukocyte count and ESR is increased. This condition is self-limited, and the patient reaches to the euthyroid state within 6 to 8 weeks. Coming to the other forms of thyroiditis, that is Riedl's thyroiditis. In Riedl's thyroiditis, there is extensive fibrosis involving the thyroid and the contiguous neck structures. The thyroid is hard and fixed. Clinically simulates a thyroid neoplasm, which is associated with idiopathic fibrosis of the retroperitoneum, which is an autoimmune condition. Coming to the palpation thyroiditis, this thyroiditis is generally caused by vigorous clinical palpation of the thyroid gland. There is multifocal follicular disruption and the chronic inflammatory cells and occasional giant cells can be seen. Thank you.